I want to thank Charles. Dr. Blum and I go back 15, 20 years fighting the issues of the research supportive of SOT and the cranial concept. And so I'm delighted to be here to share with you the osteopathic perspective on what we call the cranial concept. I'm kind of a wonk into the literature. When I started giving this lecture, 15, 16 years ago, I had about 30 slides. I now have 130. So I want to say I hope you get the melody and don't worry too much about all the notes, because this presentation is available to all of you. I even agreed with Charles to record it for YouTube, so that is something I'm willing to kind of go public with. Right now, I am a clinical professor of family medicine at the University of California, San Diego School of Medicine. I'm infiltrating the allopathic world on behalf of osteopathy and what we can do with the professions that use their hands in healthcare. And I'm doing a lot of research, which I will share with you later. All the slides here. In true professorial, we just have to talk about learning objectives. I want to describe the cranial concept, the 5 phenomena of the primary respiratory mechanism, and the research which supports the concept, and then the clinical research that is badly needed to gain credibility within the healthcare world. You know, in this day of evidence-based medicine, what proof do you have is something that you need to demonstrate. So this is, my conclusion is that as far as the cranial-oriented techniques, it is not proven yet with the systematic review, meta-analysis, Cochrane review literature that is accepted as proof these days of the validity of a medical procedure. But there's more than enough research to, from my perspective, is to convince patients that we know what we're doing, and when we're teaching the medical students who are constantly challenging us for the evidence base, that we can say there is an evidence base for the application of the cranial treatment principles. I am rather ecumenical. Back in '89 and '90, I went to work with John Upledger at the Upledger Institute, taught craniosacral therapy, and we had all sorts of folks, the chiropractors, the physical therapists, massage workers, and what I found is that the teaching of the cranial concept from the craniosacral therapy and the osteopathic perspective, it made everyone a better practitioner. They gained in palpatory experience, and they gained in some techniques. And I am very comfortable teaching non-physician osteopaths worldwide. I do a fair amount of travel teaching the principles of, I do all of osteopathy, but I am focused on the cranial concept because I think this is something that is going to be very useful as the evidence base gains in the neurosciences, everything neurological, what you do with your hands, with the head and sacrum, the central nervous system, everything that's within the dura mater that surrounds the brain and spinal cord, connects the sacrum and the head. The anatomy is there. How do you use it? And this is what we are teaching with the osteopathic approach to cranial. In 2005, I went to the Osteopathic Research Center, and we had a number of, then NCAM, it's now the National Center for Integrative and Holistic Medicine. And Christine Gertz, DC at Palmer, was one of our program directors, and Partap Kalza. I don't know if you know these names. He was one of the main program managers for several of the grants that we had at the Osteopathic Research Center, and I got to know Partap really pretty well. And I came to appreciate fully the research. For research, The DC PhDs are just as good as any MD PhD because you are embedded in the scientific method. And so I have great respect, for the research. And I said, I'm glad that NIH NCAM is supporting us with osteopathic research. And Partep said, a rising tide floats all boats. And so the research is really important for the credibility as far as treating our fellow man clinically. And then, of course, getting reimbursed is important. And so we have proof that the insurance companies cannot deny that what we do with our hands works. The cranial stuff's been around for thousands of years. Trephination, I just throw that in. From the osteopathic perspective, William Garner Sutherland was the originator. He was a student of Andrew Taylor Still, and he went public with it in 1944. And it has been said that Sutherland did for the head what Still did for the rest of the body in terms of delineating the anatomy and how you can intervene therapeutically with using a cranial. This is A.T. Still doing some kind of upper cervical. Maybe he was NUCA before there was NUCA. I don't know. My phrase is, good hands speak for themselves. If you've got good hands, you can feel what's going on. And so I developed that touch. Sutherland's insight was when he saw the disarticulated skull, these beveled edges between the temporal bone and parietal, they're not bluntly attached, they slide. And he called this like a gills of a fish. Uh-oh, this is on, sorry. I moved. I was told I should stand right here. Am I my background supposed to be? Yes, okay. That was the inspiration that he had, that the cranial bones were supposed to move in some way. Probably within the osteopathic profession, the professional society that promulgates and teaches this most is the Osteopathic Cranial Academy. And so I just give that a plug. I'm a past board member and all that kind of stuff. The 5 phenomena of the cranial concept has gone through some different wording over the past 50 years. The current wording, the primary respiratory mechanism, is what Sutherland promulgated. And there are 5 phenomena. The inherent rhythmic motion of the brain and spinal cord, the fluctuation of CSF that bathes and nourishes the brain and spinal cord. And I'm ending up today with some discussion about how enhancing CSF flow is possibly a good treatment for dementia and Alzheimer's. All that beta amyloid plaque that build up in the brains of people with dementia and Alzheimer's. We do have, in my opinion, a set of techniques that can stimulate the CSF flow and just flush out all of that stuff. And I tried at the Alzheimer's Research Center at UCSD to get a study going, and what they said that was lacking was the proper outcome measures. What biomarkers? There really is not yet a good biomarker for Alzheimer's that you would think would be showing a before and after effect. But I am of the opinion that we have a lot to offer by being able to manipulate the brain and spinal cord in such a way that activates CSF flow. Another important is the mobility of the intracranial and spinal membranes. I've got a slide that shows how you can measure the dura mater, the falx, and the tentorium on a cadaver to show that these membranes inside the head do move. Fourth, the articular mobility of the cranial bones, and then the involuntary motion of the sacrum between the ilia. All of these elements are what Sutherland proposed as the primary respiratory mechanism. In Sutherland's first edition of Osteopathy in the Cranial Field, by the way, the terminology, when I started in the late 70s, It was called OCF, osteopathy in the cranial field, sometimes referred to as cranial osteopathy. And now, on my front slide, the Journal of the American Osteopathic Association, the nomenclature is Cranial Osteopathic Manipulative Medicine. For the last 10, 12 years, the osteopathic medical profession has been trying to put that word medical in there every chance they get. I'm supposedly an osteopathic physician. I'm happy to be called an osteopath. I think that that embodies the philosophy the most accurately, and so I'm very happy to consider myself an osteopath. And that the primary respiratory mechanism is the dynamic manifestation of vitality of life. And these are the biomechanical parts that manifest this in the body. That's the philosophy. The point I make is that 4 of these phenomena are not controversial. And I'll go through the evidence base for all of these phenomena. The one controversial one is the cranial bone motion. Now, this is quickly the evidence for the inherent rhythmic motion of the brain and spinal cord. Since the late 80s, early 90s, there's just been no question but that the parenchyma of the brain moves, and it's been measured. You know, you can see this on cine radiography. You can see the brain tissue moving. So there's no question that what's going on inside the head is moving around. In fact, they talk about the displacement of the part of the brain. The brain motion consists of a single displacement in systole followed by a slow return in diastole. And this descent of the midbrain and towards the foramen magnum, velocities of around 2 millimeters per second. They've even measured the rate of the movement, and the compression of the thalami in the third ventricle is measurable at 1.5 millimeters per second. And pretty much it's associated with the cardiac cycle. Other research, the velocity of the anterior cortex, they're measuring the motion of the brain. And the melody here is that the brain is moving. The fluctuation of the cerebral spinal fluid since the 1970s, there's no question that the CSF flows, and it is supposedly correlated with the cardiac flow. The reason I say supposedly is that I think there are other physiologic mechanisms besides the heart rhythm motivating all of these fluids. But as we relate to our anatomic, scientific, physiology, medical researchers to go with the vascular system as the primary force, I think is still a viable thing. The fluctuation, there's a number of studies. It's interesting, the differences in the measured flow of the CSF in the spinal canal. Healthy CSF flows at a rate of 12.4 plus minus 2 millimeters per second. However, if you have the spinal dysreflexia, like that spina bifida, if you have an abnormal vertebral column, that slows down the rate of flow. So that's an interesting thing that these researchers found. The mobility of the intracranial and interspinal membranes. We call it the reciprocal tension membrane, and the existence of this anatomy is not controversial. It's the dura mater. I love that. Dura mater's tough mother. This membrane will bend like a garden hose, but it doesn't stretch worth a hoot. And that's the basis of, from the foramen magnum into the sacrum, it's like a puppet on a string. And so the dural membrane tensions are part of what we work with clinically to figure out how to work with it from the manipulation, the palpatory skill. Back on that slide on the Osteopathic Cranial Academy, Sutherland called it motility or inherent motion. And this is still a matter of controversy. That it moves, is mobile, is not questioned. The issue of what is the motive force. Is it just the vascular flow? Is it breathing? Sutherland talks about the vital force, an inherent dynamism in the body. And that has been really hard to demonstrate empirically. But I have to be honest in saying that this is part of what we think.
The maxilla contains a number of teeth which go to various parts of the body. It supports the structures of the face. It holds the nose into position and embraces the forehead and helps you look like somebody. Now, every person that comes in, we test to see if the three membranes are flexible and will go as far as they should to the left or to the right. And we do this by picking up the head and placing the hand under the head with the occiput riding on this part of
hemispheres.
The fingers.
And they did procedures called the frontal lift and the parietal lift. And through this window photographing with these sensors, they show that these membranes move as you are externally with your hands on the cranial bones doing, you make enough contact where your fingers don't slide on the head and you lift up. The frontal bone, you're going this way, the parietal bones, you're going this way. And lo and behold, those membranes move. So that was, the controversy that this kind of settled was, can outside palpatory forces actually move the dural membranes inside the head? And so pretty much now it's cadaver. And the interesting thing is embalmed tissue is much more rigid than live unembalmed tissue. And you still got this effect. One of the interesting things about the sacrum, and I really have appreciation of SOT, you got the sacrum in there. And so that's really an important thing. Believe it or not, up until about 150 years ago, science held that the SI joint didn't move. Do you realize the flat earth mentality of that? I mean, if the SI did not move, we'd be walking like that, but the SI was made to move. And fortunately, simple radiology experiment studies have shown that the sacrum rocks a good 2 to 3 millimeters between inhalation and exhalation. There's no question that the sacrum moves. So it's these 4 of the 5 phenomena of Sutherland's proposed primary respiratory mechanism are not controversial. They're accepted by science. It's the articular mobility of the cranial bones. That's been the biggest criticism of the cranial concept. And do cranial bones move? How can they move? I mean, they get moved all the time. Look at the lumps and bumps and tumbles of life. You can really, do all sorts of things to mold the bones of the head. You can really work with that. Later on, I'll talk about treating plagiocephaly, the crooked heads, the cone heads. In fact, this is what we like to demonstrate when we're teaching the basic cranial. Feel the back of your head. Do you feel a little bump back there? Yep. Most people have that. And the cranial osteopathic perspective is that's your leftover cone head. That there was some molding. And to the degree that that's prominent, you probably had more molding and cranial bone distortion. You can live with half a brain, and that's to get your attention. About cranial bones move. The perspective in medical science for years was that the cranial bones cannot move. And this was based mostly on research in the 1915, 1920 from forensic anthropology research that was designed to determine the age at death. This is from anthropology, forensic anthropology, and these guys, Todd and Lyon, they published in the 20s that the cranial sutures are ossified and they can't move. And in 1991, these guys said that it's impossible for cranial bones to move. And of course, I've been doing cranial since 1979, and I said, yeah, those daggum things move, but I didn't have any proof. And the criticism has been very, very strong. When you go inside the data and they put all this data, Paul Dart, a dentist who works with us in the Cranial Academy, he pointed out in analyzing the Todd and Lyon data that they were attempting to establish modal norms for suture closure that would correlate with the age of death. So the pathologists and anthropologists could contribute to understanding that. And the bottom line of this is that many of the specimens were excluded from this analysis because of prolonged sutural patency. And this distorted the conclusion. The idea is if you can see the sutures, they're probably able to be moved. And it is possible for those sutures to ossify. And yes, that adversely affects or reduces the palpatory motion of the cranial bone movement that you can perceive. There was a lot of animal studies that showed cranial bone histology, and this is the list. This is all pretty much done at Michigan State University College of Osteopathic Medicine, that they're making the case that the sutures of the head were made to be moved. And in '87, Ernie Retzlaff and Fred Mitchell Jr. Published this book, The Cranium and Its Sutures. And one of the main things they showed is, again, this between the temporal bone and the parietal bone that was made to slide. And it was made to move. One way you can look at it is it was Mother Nature made our skull this way so that it could absorb trauma. It wouldn't break like a crystal ball or vase. That it's part of the head's capacity to absorb a blow. We, of course, think that as I'll show later, the intracranial fluid volume fluctuations, that the cranial bones move in relation to that. And all sorts of, the Sharpie's ligaments that go across these cranial sutures that hold it together. So there is connective tissue that in these sutures that hold the cranial bones together. Finally, in 2006, there was a fairly organized, good study on occipital sutures, 36 human cadaver skulls. And each suture was described using a grading scale. And they were looking at the coronal suture, the sagittal suture, and the occipital suture. And they concluded the lambdoid was most likely to be patent and to least likely to be obliterated when compared with the sagittal suture. There were no differences between males and females, and there were no differences based on the age of the specimen. And so this was the scale that they used. And this is a good picture of the degree of suture patency. And the cynic in me says, okay, this is external. Does that suture go all the way through? Is it on the inner surface of the calvarium? Can it be at the bottom part more stuck and ossified? And as best we can tell is no, if you can see it, it's through and through a patent suture. And these were the grades, 1, 2, 3, 4. And yes, it certainly is possible to have all these sutures obliterated. And yes, we call these bowling ball heads when you feel them. And they are harder to work with. And usually the only thing you can really do is get the OA, occipital-atlantal junction, moving to help these folks. The lambdoid suture was more frequently patent. They think due to the larger number of muscles attached to the occiput than in the area of the sagittal suture on the top of the head. The theory that external forces maintain suture patency and complexity can be supported by the morphological studies of the facial sutures. Basically, they're making the point that if there are more muscles attached to those bones for when you're chewing and moving, that you're likely to keep those sutures patent. There was a whole, about 20 slides in this presentation. The point of this was that the degree of sutural obliteration was related to somatic dysfunction in the body, the spine. If you had ankylosing spondylitis, you had spinal fusions, metal in there, that the patients that had that were much more likely to have the cranial suture obliteration. So from the osteopathic perspective, the cranial is tied into the rest of the body. If you have screw-ups in the sacrum, vertebral column, it's going to have an adverse effect on the cranium. And for me, I go, duh, that's just, everything's interconnected. And you can make that case so well. The biomechanical studies on cranial bone motion. My mentor, Viola Fryman, used this device, and yes, she found cranial bone motion that was not correlated with respiration or with the heartbeat. Two neurologists back in '81 on comatose patients, they actually did a spinal tap and they pumped fluid into the subdural space, and lo and behold, on this rather rudimentary way of measuring cranial bone motion, found that the cranial bones did move as you changed the pressure of the CSF. On animals, the same thing. You put them in a stereotaxic, and they had normal saline that they put into the subdural space, and they measured the cranial bone motion. Supporting the idea that the change intracranial fluid volume makes the cranial bones move. Then we have NASA. The reason that NASA got into the story is they were worried about all the astronauts going out into space and then fainting because they don't have enough blood flow to the head. And they were concerned about the physiology of brain chemistry and the oxygenation of the blood, getting oxygen to the brain. There's a whole series of studies here. When these came out, I stood up in a cranial conference and I said, it is now the official policy of the United States government that cranial bones move. And got a laugh. But they used very high-tech ultrasound sensors, and they started out 3 fresh cadavers. You pump saline in the third ventricle at the rate of 1 cycle per second, and it made the skull expansion, 29 micrometers. This research went on with live people. Toshiaki Ueno, who, by the way, all of this NASA research done at the Livermore Labs up in the Bay Area was going full tilt until the Challenger disaster, when the space shuttle blew up. And it really hampered the funds, and this research was pretty much shut down by the government. But there was been enough published. Basically, upright, there's not that much motion. But if you tilt somebody down just to 10 degrees below horizontal, you see as much as a millimeter of cranial bone expansion. And so the folks at NASA were really quite supportive. in showing that the cranial bones do move, or giving this evidence. And a number of articles, this was one of the, I give you the reference, you can look it up, cranial diameter pulsations measured by non-invasive ultrasound decrease with tilt. In other words, when cranial pressure increased, arterial pulsation produces a higher amplitude of intracranial pressure pulsation. Increased amplitude of intracranial pulsations will be manifested by larger fluctuations in the distance across the skull. Although the skull, this is quotes out of their article, revolutionary. Although the skull is often assumed to be a rigid container with a constant volume, we and others have demonstrated the skull moves on the order of a few microns in association with arterial pressure, systolic, diastolic, and changes in intracranial fluid pressure. Now, the Russian cosmonaut program was also interested in this. And Yuri Moskalenko, I am going to St. Petersburg, Russia, June 23rd to July 3rd to work again with Yuri Moskalenko. What the USA, Russian research is not widely accepted. And so I think he's done a lot of interesting work. It is published in peer-reviewed journals, but it's all European. And the USA medical scientific community tend not to give it much credence. But he essentially found the same thing, that the cranial bones do move, and he talks about, he was using tomograms. You remember when what we now called MRI first came out, they called it nuclear magnetic resonance. And that was abbreviated, meaning no more radiologists. And so they changed it to MRI, which is more radiologists immediately. You know, that's just testing to see if you're awake, you know. Early technology that the Russians used that talks about the mean amplitude is 0.38 plus or minus 2.1, 18 folks with a maximum deviation of up to 1 millimeter. You know, if the bones are totally ossified, you should expect no motion. But you're getting these microns to a millimeter range of motion. And he said that the intracranial fluid volume increases by 12 to 15 milliliters. A tablespoon, 15 milliliters, this is about a tablespoon of fluid. The brain tissue doesn't compress. So something's got to move to accommodate as much as a tablespoon of additional fluid one way or the other. And this is something I wish he hadn't done, the frequency of 6 to 14 cycles per minute. There does seem to be a cyclicity to this motion. This is Yuri Moskalenko and my mentor Viola Fryman at a conference back in 2001. And he's 85 now, and we're going to go to Russia and videotape him and try to replicate his work so that we can bring his research more into the mainstream of the medical scientific research. Now, there's been other research suggesting that the cranial motion, called the cranial rhythmic impulse, Sutherland never talked about a rate of motion. It was simply the amplitude. And back in 1962, osteopaths working at the Still Hildreth Sanitarium in Missouri talked about a rate of motion. And their point was that people who are psychiatrically impaired and about to die had a slower motion of the cranial bone. I think the quality of that motion is more important than a quantified rate. But my friend Ken Nelson and Niset Sergev and Tom Galonic, he's the PhD whose lab all this, you know, the guy whose lab is always the last one. Basically, if you've heard of the Traub-Herring-Meyer oscillation, and it's 4 to 5 cycles per minute, and it seems to be associated with respiration. And they were saying, well, that's what's making this motion. And we had a conference in 1994. Here's Toshiaki Ueno, Tom Glonick, Ken Nelson, Moskalenko, and Fryman, where we were presenting the data related to the primary respiratory mechanism. And Toshiaki would not give us the slides, but he showed all the astronauts before blast off and when they would come down and be picked up on the aircraft carrier, their heads were like melons when they came back down. And it took a day or two of gravity to have the configuration of the head be more normal. And they're holding back these to the eye test, looking at it, you can just see these heads. You know, the most recent thing I would suggest is Kelly, the twin brother of the husband of Gabby Giffords, who was out in, and this is just in the last couple of years, he was out in space for about a year, and he came down, and he was 6 feet tall, and his normal Earth height was 5'10". And it took him about a month for gravity to pull his structure back to his normal gravitational pull height. And so when you put these kind of pictorial things and experience, the fluidity and the motion of the neuromusculoskeletal system, and particularly the cranial bone motion, is something you have to consider. I was involved in a study of 20 healthy subjects. We had 8 MRI images through the same coronal plane, this. And there's an image analysis system from NIH called ImageJ. And we had their heads in this stabilizing thing. I thought that the head stabilization would diminish the cranial bone motion, but we had to do this to demonstrate that we had no movement artifact. In other words, the image would be shaky because the head was moving. And basically, there were a number of dimensions across the skull that were statistically significant. However, we were limited by the definition of these MRI images about the number of pixels to give an accurate measure. And so we were not able to say that these other things, you know, the height, width parameter, but there were enough pixels in the area within the calvarium that indeed it was quite significant. You had these 8 images, and you analyzed with ImageJ, and you got the number of pixels, and to show that the cranial bone, the area inside the skull was actually changing from a minimum volume, area to a maximum area at this 0.003 level. We were pleased to see this kind of motion even though the head was stabilized so firmly. So the cranial bones were shown in this study to move, and it was healthy people. They were mostly residents and interns at this hospital. And I contended, since I wrote the article, the calvarial structures moved in some way. We couldn't say what made it move, but it moved. And then the issue comes with these millimeter micron motions. Is the human sense of touch sensitive enough to actually feel these motions? And lo and behold, it is. This is a study in just fairly recently, 14 osteopaths. This is out of Belgium. Belgian osteopaths had this device that had one of your activators in it. You could really control the dimension of how much. Of course, the top wasn't on, and the subject would be asked do you feel anything? And what they showed were that non-osteopaths could feel it just as well as the osteopaths. So it's not training, it's just human sense of touch. And that you could feel the motion down to 50 microns, 100 microns. You know, It's very subtle, small. You need a microscope to see, microns, but you can feel this motion. So the circle is closing in terms of the evidence for cranial bone motion is there, and the human sense of touch to feel it is there. Now, this is one of my pet peeves, and this is where Charles and I really kind of joined forces to counteract Hartman and Norton. In 2000, they said that there was no evidence showing the cranial concept, and they picked this cranial rhythmic impulse to measure the rate of the motion. And it really got personal. I wrote a co-author of the chapter on osteopathy in the cranial field in our foundations text, the second edition in 2002. And they ripped me a new cloaca for how unscientific this was. And they disputed the data. Upledger, in his Michigan State days, had a well-designed study with 4 different practitioners, and their inter-examiner coefficient was 0.79, a significant finding. And as with any inter-examiner reliability study, if you prepare and you practice it on the same heads, do this. In other words, it takes practice to get a good inter-examiner reliability. So everyone knows they're measuring the same thing. And essentially, Hartman and Norton reanalyzed his data, and their criticism was that it was incomplete, and they eliminated a number of the 25, these were all autistic kids. They were 25, age 3 to 5, and they reinterpreted his data and said that it was insignificant. And then what really yanked my chain was a pilot study that was only an abstract. Kay Drengler and I, we assessed the CRI, and from the osteopathic perspective, it's not the rate, it's the amplitude. It's like a pulse. Is it a bounding pulse, or is it kind of a weak, thready pulse? And the CRI data were all over the place, totally insignificant. And there's just 10 doctors, 10 patients, and 2 of my colleagues, who shall remain nameless. You can see they were pretty much on the long tide. In the concept of cranial rate, you have the long tide, there's a flexion and extension about every 90 to 100 seconds, and then you have one that supposedly goes from 8 to 10 cycles. And there were 2 people that really had these low numbers, and it just totally skewed everything for the other 8. But then, when the health index, which was the vitality of the person, that was significant. And Hartman and Norton completely ignored this data and misrepresented the Drengler and King study. And so I've complained about that for years. And the clinical work, the one criticism Hartman and Norton had was there wasn't enough clinical demonstration. And so, clinical stuff. There have actually now been 2 systematic reviews. And the good news is that when you get systematic reviews, it means there's some credibility, there's something there. Although they concluded that more research was needed. And then a second one, it was more on cranial sacral therapy, and again, further studies are needed. My criticism, and this, the one in the JAOA, I was able to review, and I complained that they did not include all the relevant research. And the reason that they gave was that the research here, Fryman called it osteopathic manipulative treatment. She didn't say cranial treatment. And just because of that lack of nomenclature, these 3 studies that showed the clinical benefit of the cranial treatment were ignored. So some of the more interesting Sleep, I was interested in what you're talking about, oxygenation and sleep. There's a technique called the CV4, the compression of the fourth ventricle. I wish I could teach it to you. It's sometimes called the osteopathic aspirin. I don't know if it's really related to the atlas or nuca or not, because you're resting the occipital bone on the thenar eminences. And just the weight of the head and a little bit of induction of pulling the head towards you that we call cranial extension, you can get a profound relaxation response. Our hypothesis is that in the fourth ventricle, which is a wide spot in the spinal canal, that with just these minimal forces through the occipital bone, you actually narrow the lumen of the spinal canal in this wide spot on the road called the fourth ventricle. And that, in accordance with Poisson's, my French, that's the only word I can say, Poisson's law of physics is that if you narrow the lumen of a tube through which fluid is flowing, it will speed up the flow of that fluid. And that is the basis of why I think that if you stimulate CSF flow, you're going to help people with head off dementia and Alzheimer's by increasing CSF flow, flushing out the brain of all the waste products of cellular metabolism, all that carbon dioxide and lactic acid that brain cells emit. Anyway, in 2005, Cutler et al. Did a CV4, and they showed that it significantly increased how fast you fall asleep over a control or a sham CV4, which was just, they had their hands on the head, but they didn't do anything treating. And then they did this microneurography in the peroneal nerve. And lo and behold, in doing the muscle sympathetic nerve activity decreases when you do a CV4 and you reach a still point. Newborns and children. I think I'm running out of time. I'm going to blast through this. I don't know how many of you work with children, but Freiman was big on doing the cranial work on the children to straighten out the crooked, as a twig is bent, so grows the tree. And this is at St. Barnabas Hospital. This is a neuromusculoskeletal system residency, and they evaluate all the newborns. And this is what I wish could happen in every newborn nursery. Otitis media. Several studies show the benefit of the cranial bone manipulation. Mills et al. Basically, there were fewer otitis media episodes, significant, fewer myringotomy tubes, significant, and more normal tympanograms, significant, if you did this cranial manipulation on the kiddos. Karen Steele and Jane Carrero, they used tympanography and acoustic reflectometry, which was something the parents could do at home. And the middle ear effusion after 3 visits was significantly less as measured by tympanograms and acoustic reflectometry. Taken another way, these are Canadian osteopaths. Earlier I saw that about the derangement or malalignment of the temporal bone that you can palpate in children that had the temporal bone status. It was out of position, that those kids with severe restriction of temporal bone motion had a much higher rate of ear infections than non-restricted. It wasn't statistically significant, but I offer this as further corroborative evidence about the cranial bone malalignment having pathology problems. In the neonatal ICU, this is all done in Italy, in the neonatal intensive care unit, that the application of the cranial manipulation lowered the occurrence of the incidence of gastrointestinal dysfunction, and it reduced the length of stay in the NICU. There was a second study that the first one was just a consecutive series. This was a randomized trial, and they used cranial and indirect fluidic and V-spread techniques for 10 minutes. The control group, they had the bassinets, and so that the staff wouldn't know if they were doing the actual treatment or not. They would stand there with their hands inside, and no one was. In other words, there was a fairly convincing control group. And they showed that the length of stay was significantly less for the treated youngsters than for the non-treated. Another study showed the same thing, a reduced length of stay. However, this went on to say that the earlier the OMT began, the less the length of stay. The implication being that as soon as you identify these youngsters, you need to move ahead and do the intervention. And then the piece de resistance was a multi-center study where they had an N of 695 in these three centers, and statistically significant reduced length of stay. And here's where we really impact the healthcare system. We show how we save money to insurance companies, and now this is in Italy. They have a socialized medicine system there. But if you can pay less and get a good result, this is how, per case, 1,500 euros, less money if they got the OMT. And it's that kind of data that really helps us. This meta-analysis has just been published. One of my pet things is also plagiocephaly, the crooked heads. Birth trauma, oh my gosh. I mean, this is a spina bifida, but you can see the misshapen heads that can come out with a difficult labor and delivery, the use of forceps. Freiman, in 1966, she evaluated 1,250 infants. 88% had some identifiable malalignment in the form of cranial bone strain patterns. Much more common than you might think. The dysmorphology clinic at UCSD also showed the occurrence of misshapen heads. 73% of newborns had at least one asymmetry. 10 had more than one. And so the data is there. The only published study, this is out of Canada, Sylvie Lessard, non-synesthetic occipital plagiocephaly. This started with the Back to Sleep program, that the sudden infant death, they didn't want the babies to be put to sleep on their stomachs. And so they always had them on their back, and laying on their back flattened the head. I think some of that cranial dysmorphology came also from a difficult labor and delivery. And 12 infants, and they measured there were 3 skull base asymmetry, cranial asymmetry, and transcranial vault asymmetry. And to make an interesting study, now this is just 12 consecutive patients. It was not a control group, but before and after, there was statistically significant normalization and improvement in these dimensions that measure plagiocephaly. So if you intervene early, you really can help the configuration of the head. And the data show that kids with crooked heads, plagiocephaly, have more cognitive problems later in life. And so we set them up for just a better life by getting the cranial structures improved. Balance and equilibrium. Here, the big public health issue is if you can help balance and equilibrium, our elders don't fall down and break hips and cause lots of problems. I was a part of a study, 40 healthy elders, greater than 65, and it was a balance plate, and the data with eyes open, and they had eyes closed, and then they had the Romberg test here, but this was the most common sway problem is an anterior-posterior, and the cranial manipulation significantly improved this stability, there was much less sway, and so this is our evidence that it helps healthy elders. And this was the protocol. There was a lot of soft tissue structural work, the venous sinus technique, the CV4. For patients with dizziness, Marcel Frey over in Pomona, this is world-class high-tech balance and equilibrium device. And basically, he did cranial treatment on them, and it improved. It was stable immediately after the OMT and 1 week after. That their ability to show equilibrium and balance stability on this very well constructed, the outcome measures are scientifically accepted. Immune system function, another one of my favorite things. Someone was talking about IgA earlier. You can see they're all doing cervical and cranial work. There were N of 12 in the experimental group and the control group, and they did these buccal swabs. This was the group that had they had just rested, just laid there. And there was just rest increased the IgA measure 24%. If they got the cranial manipulation, it was 59% increased if in this IgA. Nervous system effects, alpha rhythm. Some Brazilian physical therapists, I got this article to review and it was really not in good shape, so I helped them revise it, and so I got my name on it. But basically, the CV4 increases alpha rhythm, has this effect of a neurology, it increases alpha rhythm. We don't know what it means, but the same thing, the CV4, increases cerebral blood tissue oxygenation. Not sure what that means, but it was statistically significant. The suppression technique actually was a CV4, and they felt they needed to use that terminology. Tinnitus, headache. Tinnitus, I worked with Josh Alexander, who's a DO neurologist, and here the data show that it helps reduce sensory neural tinnitus, which is a tinnitus brought about by cranial bone trauma. That if you move your head, your jaw out, it changes the ringing in the ear sensation. Headache, migraine. On the headache impact test, they did, this was cranial sacral therapy, and lo and behold, after the cranial sacral therapy, it brings about a reduction in the scale of headache impact test. Here's where I really want to go. And this was a cranial sacral therapist at this Army base it was Beaumont Army Medical Center in El Paso, that the application of the cranial sacral reduced the symptoms and increased cognitive functioning in the wounded warriors with post-traumatic stress disorder and with TBI. And so this is the only one so far that I'm aware of that suggests that the application of cranial manipulation, be it osteopathic or cranial sacral therapy, has some benefit in cases of TBI and post-traumatic stress disorder. Fryman, on kids with seizures, she showed out of an N of 87 that she was able, after a series of cranial treatments, no seizures, no medication. General well-being much improved, 55. So you got 75 out of 87 that were significantly improved, and a few dropped out, a few got worse. Again, this is observational data. You can't really do a statistical analysis on it, but I cite it as, an application to a neurological condition that the hands-on work can actually help. In Israel, there's a study on multiple sclerosis, cranial sacral therapy, on urinary tract signs and symptoms in multiple sclerosis. And, I guess the slide with the data. Basically, the voiding volume and the frequency of urination were improved after the application of cranial sacral therapy. I'm now just starting a study at UCSD to measure interocular pressure in glaucoma. I'll beat that. Okay. And doing orbital technique. This is the TBI Alzheimer's, the glymphatic system. I'm sure you've all heard of the glymphatic system now, and basically they're talking about CSF in the brain. And now lymphatic, the whole thing about the glymphatic system is that for a long time science said there were no lymphatic vessels in the brain, and that there had to be a way of flushing out the brain, and that was the CSF. And now they have actually, 2 studies have shown that there are lymph vessels in the dural membranes. And so this brings immune system activity into possible impact on brain function. That's it.